Thailand, and hello all my Turkey friends. So I will start. Oh, it says host disabled participant screen sharing. Fazla, I can't share my
Bülent,
screen.
Bülent, Bülent,
I'll
yeah,
give the permission.
okay, Bülent. Mhm.
Try again. Okay. Yeah. Thank you for having me. I wish I was in Turkey, seeing my Turkey friends and enjoying the Turkish food. But anyway, this is the next alternative. So I'm going to talk about protracted bacterial bronchitis or PBB. So I'm not going to say protracted bacterial bronchitis all the time. I'm just going to say PBB. So how common is PBB? Oops, my slides move. How common is PBB? So this is a study that we did in Brisbane, a multi-center study, and we found that PBB was 41% of the children that we saw first referred to respiratory physicians in our country in Australia. What about Turkey? So this is a summary of the studies in Turkey. Some of you are probably in these. And you can see the first one by Asil Soy. PBB was 23%, by Gedak was 12%, by Caramel was again a percentage. And so it varies a little bit. The last one by
لا لا بس
was a study only using dry cough, so they didn't actually describe PBB. So even in Turkey, you can see that PBB is actually relatively common, referred to Turkish centers. The other thing about PBB is that it actually causes burden, but this is Australian data. It's going to be different in Turkey. We found that children with chronic cough, they actually see a doctor multiple times until the cough resolves. And in this particular study, something like more than 80% saw a doctor more than 5 times. So the patients really doctor shop until the cough resolves. So over the next 40 minutes or so, I'll talk about three main things. One is defining PBB. Second thing is the pathobiology of PBB. Third is the clinical features and the management. So starting with defining PBB, I'll talk about the original criteria that we used and then the subsequent consensus. So what is PBB? The original description we actually saw in clinical practice first. So we came up with this description before we started the study. We said that the children had to have a chronic moist cough or wet cough of more than 4 weeks. They had to have a positive bronchoalveolar lavage bacterial culture, and they have to respond to antibiotics within 2 weeks. So the cough had to resolve with the antibiotics. So as I mentioned, we saw this in clinical practice for years and years. And then Julie Marchand here wanted to do her PhD. So I started this study project for her. And in her study, we put all the children through a protocol until their cough resolves. So you can see the protocol there. I won't go through it. And we were actually quite surprised, but we thought maybe we'll get about 20-30%, but we actually got 40% of children who fulfilled the criteria. So this was a prospective study. The definition was a priori defined. So I think all of you would know. So this is a bronchoscopy of a child with PBB. You can see some secretions there, a little bit of Malaysia, and you can see the secretions in the airways, which is pretty marked. Okay. So when you mention the new condition, you got to go through each criteria and ask yourself, are the criteria valid? So concurrently, we looked at the criteria of wet cough, because some people use it clinically, but nobody really actually looked at it in a scientific manner. So we asked the question, is wet cough a valid thing? Because that's what we asked the parents and when we listen to the child. So we took 106 kids. We enrolled them before a bronchoscopy. You can see that the median age was young. The cough was digitally recorded. Doctors were blinded to it. The parents were asked what the cough was like. The cough was registered by a research assistant, and the doctor that was blinded also assessed the cough from the recording. And the agreement between parents and doctors was 0.75, which is very good. In clinical medicine, anything above 0.4 is good enough. And then interclination, so two senior doctors, which is Dr. Masters and I, our agreement was 0.88. So you can see that it's actually a good, it's not perfect, but it's a valid thing in clinical use. So we then, in the bronchoscopy, we actually produced this first. We developed a chart, and then we scored the chart, and you can see this is the area under the curve of 0.85, and in clinical medicine, anything above 0.8 is very good. So you can see that it fulfills the criteria of secretions in the airway as well. So it's valid between clinicians, valid between patients and clinicians, and valid comparing the cough sound to a bronchoscopy findings. The second criteria is positive BAL culture. This is pretty straightforward. We defined it at that time as single growth of a colony of more than 10 to the power of 5 colony forming units per mil, and the normal bacteria. They had at that time to have no viruses. Nowadays we accept it, but because we wanted to be very strict, we said they didn't have the viruses, and they also had to be chlamydia and mycoplasma negative. So the third thing was response to antibiotics. Again, we found that in our cohort, they usually need about 10 to 14 days. That's a clinical thing. And then we went to do a Cochrane review. The first two names was before Julie did her study. So at the same time, we were doing a study, randomized controlled trial study, but she had 4 children between her PhD, so it was published very late. But prior to that, we did the Cochrane review consisting of the first two. But if you add Julie's study in, you can see that the diamond shape definitely favors antibiotics. So we know that it works. So have people described PBB-like conditions before? And the answer is yes, because obviously this is not a new thing. It's just that it's been described and quantified now. So we actually have a name, we actually have criteria, and we actually have biological data as well. So if you look for all conditions, really all the way back to Elaine Field, who is a star in bronchiectasis back in the 1940s and 1950s, she talked about a pre-bronchiectatic state. Okay, so she's described this condition as well. And then if you go back to the 80s, Lynn Tosick also spoke about, this thing about cough, and other data has looked at the bacterial flora in children with asthma, but I don't think they all had asthma. They actually had an asthma-like condition, which is actually PBB. So other people have described bacteria in the airways and cough and responding to antibiotics in a different sort of a way, but they didn't actually put it all together in a nice way. So we obviously don't expect every single person to undergo bronchoscopy. So we've now termed our original description as PBB micro. We've replaced the microbiology, when you cannot get sputum or bronchoalveolar lavage, with the absence of other causes of wet cough. So we call it PBB clinical, so that they fulfill the criteria except for the BAL component. And we also called the PBB extended because we then subsequently realized that some children will actually need 4 weeks of antibiotics rather than 2 weeks of antibiotics. And to help us in future research and to help people, we call it PBB extended. So the current PBB is PBB that's been present for 3 episodes for in a year, and that's important in a while, which I'll show you why. The criteria that's highlighted there has been accepted in the American chest guidelines as well as in the ERS task force. So it's kind of accepted now. So moving on to the pathobiology or pathophysiology, if you describe something new, you have to have scientific stuff to support the clinical bits as well. So I'm going to talk about a few things: inflammatory findings, inflammation pathway and gene expression findings, the immunity component, the microbiology, and then ask the question whether there's an airway abnormality as well. So this is a typical slide of a child with PBB, and you can see a lot of neutrophils here. These are neutrophils and there's macrophages. So usually your BAL consists predominantly of macrophages. So again, Julie's work, we looked at the BAL of the children with bronchitis, PBB, and we looked at other causes as well as natural resolution. And you can see there that it's significantly elevated in children with PBB. And then if you look at the neutrophilic pathway, IL-8, again, it's higher than the other groups, and similarly MM9, MMP9 as well. So there's a neutrophilic inflammation in these children. So what pathways are actually involved and what gene expression? So this is Katie Baines, who's in Newcastle, and she was interested in looking at IL-1 beta, which is again a neutrophilic pathway, which is a mediator of the inflammatory response and also a defense thing. But if it's dysregulated and persistent, it actually is harmful to the airways. So what she did was she took some of our kids who had PBB and some of the controls. She did the experimental cohort followed by a validation cohort. So in the experimental cohort, you can see that the IL-1 beta is substantially elevated compared to controls. And then when she looked at IL-1 receptor 2 as well, it is also elevated, but only by a small margin. If you look at the validation cohort, you can also see the same finding. So again, showing that this is actually a solid finding. And then she looked at other neutrophil-related mediators, and again, she found that alpha defense 1 to 3 was elevated. So it supports the simple stuff that we did earlier, just at a different level. So looking at the PCR level is different from proving it on a protein level. And so in the panel A, you can see that with the protein is also elevated. And then the receptor component, again on a protein level, it's elevated. And then she also then went on to show that the protein relates very nicely to what you see on the PCR level. So then Katie decided to ask the question. I said to her, I don't think you're going to find anything because it's such a coarse measure, duration of cough and cough score. So I'll do it anyway. So she proved me wrong. So she looked at duration of cough on the y-axis and the amount of IL-1 beta on the x-axis. And you can see that for such a gross measure, it's a very significant correlation with R level of 0.49. And then when she looked at the protein level with a cough score, the higher the cough score, i.e. the worse the cough, the higher the IL-1 beta as well. So it basically shows that there's IL-1 beta pathway dysregulation in children with PBB. Now, Alice Chen came along, who worked with John Upham. She wanted to see what part of the stimulation is actually involved, and so she looked at AIM2 as well as other types of inflammasome, and she actually shown this as well, again showing that it really is a real thing even on a very microscopic and in-depth level. So what about immunity in children with PBB? I'm going to describe very quickly adaptive, innate, and mucosal. So this is Helen Petsky's work. We decided to see whether the cough score, this is a CARIF score, which is a acute respiratory infection score comparing asthma, PBB, and controls. And you can see there in red, the children with PBB, their acute respiratory infection score was much longer and higher than the other two, which is asthma and controls. So we didn't have data beyond a 14 mark, which kind of suggests they take a long time to actually recover compared to other children, including kids with asthma. So when you look at the actual data on immunoglobulins, we actually didn't find anything in the stuff that you would do clinically. So IgG, IgA, IgM, the subclasses. In the lymphocyte subsets, we actually found elevated NK cells, but that's probably because in this particular cohort, we didn't exclude viruses. As I mentioned, it's probably the concurrent viruses as well. And this is Danielle Wurzel's work that was published a few years ago now. So we also look at the immune response in terms of vaccine response, and they all responded very nicely as well. So there's no real clear-cut immunodeficiency that's obvious on a clinical level that you and I do in clinical practice. So we looked at the other things. I thought we're going to find the immune deficiency, right? It only makes sense. So we looked at TOL, so TLR, and instead of finding low levels, we actually found elevated levels. Again, I was wrong. And then we also looked at SPA, so surface protein, surfactant protein A, MBL, which is mannose binding leptin, and effectors, to see whether these parts of the innate immunity are affected. But again, I was actually wrong. Instead of finding it low, we actually found it high. So they're obviously responding to something. That's MBL. This SPA was no different between the group. We also then looked at the stimulation itself of both the BAL cells as well as the blood, where we used lipoprotein stimulation, we used poly-IC and LTA as well. And again, we found no difference in controls versus PBB, both in the blood PBMC as well as the BAL. So we still haven't found a actual easily identified immunity even at the level of PBMC stimulation. Then Sandy Hodge came along, who's from Adelaide. She's very senior, so she decided to look at apoptosis. So I think you all will know apoptosis is dying of the cell, and if you've got dysregulated apoptosis, it's called apherocytosis. So we looked at the phagocytosis, and you can see that PBB and bronchiectasis have lower ability to phagocytosize dead cells. And then she also used it against NTHI, which is Haemophilus, because as you know, children with PBB and bronchiectasis often have Haemophilus. And we also found that with Haemophilus itself, so instead of just using dead cells, you put the Haemophilus with the other cells and hope that your macrophages will actually engulf it. But we found that children with PBB and bronchiectasis had a lower ability to engulf Haemophilus infected cells. So that's apherocytosis is also reduced. So moving on to mucosa, this is unpublished work by Steph Jokovic. We found that again, it's not low, it's actually high. This is secretory IgA in the BAL. So what about the microbiology of these children? I'm going to touch about viruses, bacteria, and microbiome. So are viruses the initiator? This is Daniel Wirz's work as well. This prospective study, 140 kids. She looked at the extended viral panel, and in a subset, she looked at the other viruses like rhinovirus and coronavirus, and it was a marginal difference. But in the standard panel, there was actually not much difference whatsoever. Well, some difference, but I think this at this point we didn't actually exclude the viruses in PBB. So in standard panel at that time, we found some differences, but in the extended viruses, there was not a lot of difference, but I think it's also a sample size problem. And these were the controls that she used in the study. Obviously, we cannot bronchoscope children willy-nilly, so most of these kids also had other respiratory illnesses. So in Danielle's work, you can see the bacteria there is mainly Haemophilus, Moraxella, and Strep pneumonia, and so these are the common viruses she found. You can see the adenovirus was very prominent, and she then went on with colleagues to type the adenovirus, and we actually found that the PBB ones were very similar to the bronchiectasis ones, as we can see that gram over there. So so what other viruses are found? So if you look at our data, so our data are all prospective data in Australia. These are the viruses that you can see. If you look at data from other countries, they're all predominantly retrospective ones. Some of them are BAL and some of them are sputum. And you can see that the data is actually very similar anyway. So, but ours is all based on CFU, so they have to have a certain amount of infection. But irrespectively, you can see that the data is very similar. I actually don't know about Turkish data in this, but maybe you guys can educate me after I finish talking. So what about the microbiome? This is Lucas Hoffman's group in Washington. Seattle, the state of Washington. And if you look at species richness, PBB is very similar to bronchiectasis. So I often have an argument with people whether PBB is a precursor or whether it's a different condition altogether. But you can see that it's actually very similar to bronchiectasis and it's different to children with cystic fibrosis. But the key thing is that it's actually very different to adults. So you can see that this is similarity index on the whole microbiome, the core microbiome, and the satellite microbiome on the right panel. And you can see that adults are actually very different to children. So again, PBB similar to bronchiectasis. CF breaks off at a different point, but the adults break off at a much further point. So this is Robin Marsh's work when she looked at PBB and controls. She found 6 different clusters. It's not really clinically relevant at this point, but really just to show you that there's also clustering when you use a microbiome based on BAL specimens. Okay, so this is the 6 clusters that she described. What about airway abnormality? So if you look at airway abnormality, does it predispose you to chronic cough or PBB? You can see the summary of studies there. There's still a lot of debate whether it's a predisposition or whether it's a result of chronic inflammation. The study in Spain in 2014 was one that compared recurrent lower respiratory infection versus no respiratory infection, and they found that it was different between the groups, but the other studies was kind of marginally present only. So it probably is a predisposition because of changes in your airway mucosa clearance, but the data is still not quite solid as yet. So just to summarize what we found in the pathobiology, we know that there's certainly airway neutrophilia supported by elevated IL-8 and MMP9. Adaptive and mucosa immunity at this point is not affected. We actually know that innate immunity is not low, but it's actually activated. We do know that apoptosis and efferocytosis are definitely impaired. We also know that there is some changes with respect to IL-1 beta pathway and the inflammasome that I mentioned about before, which is the AIM component, is also affected. And IL-1 beta has clinical correlates as well. We know that there's bacterial and virus co-infection, and there's an adenovirus particular subtype, which is similar to bronchiectasis. I've shown you the microbiota profile as well as the clusters. I haven't showed you the data on biofilm. We've actually finished the study, but we haven't actually published it yet. So, so biofilm can be found not just in children with Pseudomonas and children with bronchiectasis. We also find it in children with PBB. There's probably a degree of large airway contribution, but there's a lot of things that we don't know. Why does necrophilia persist, for example? There's lots of things that we still don't know. And obviously, I haven't done any epithelial cell dysfunction. So what about the clinical management? I'll talk about the clinical features, the management, and some follow-up studies. So again, this is Danelle's work. The original study, we didn't have that many patients. This is a prospective study. And you can see there that the only thing different between the two groups was childcare attendance, but this is univariate. When you actually look at multivariate, this is again the control group. When you look at multivariate, it's actually, it disappears. So typically, the child with PBB is less than 5 years, but we definitely have children that is older. And I don't know about you guys, but certainly I also see some colleagues who have PBB. I treat them and they also get better. I'm sure it exists out there in the adult world, but it just hasn't been consolidated. So the chronic cough interferes with the child's activity, so the parents complain about it. Some parents will tell you about wheezing or rattles, but when you try and decipher it, it's usually not the wheeze. They actually don't have any ear disease, they don't have sinus disease, they don't have failure to thrive, etc. But they can have concurrent other disease that occurs at the same time. So if you do a chest X-ray, they only have perihilar changes. It has to be otherwise normal. The basic immune function is normal. When we look at IgE and RAS, it's no higher than controls. And I've already talked about the BAL or sputum in terms of microbiology and cellularity. And they have to respond to 2 or 4 weeks of antibiotics. So this is Julie's trial, the double-blinded randomized controlled trial. So this is the first prospective one that actually targets chronic red cough. The other two that I showed you before, it was a little bit of a stretch. So she used augmentin or moxiclav for 2 weeks. The primary outcome was cough resolution or improvement in cough score by at least 75% for at least 3 days. And the subgroup underwent flexible bronchoscopy, and you can see the cough score there, very different between the PBB, very different between the children giving amoxiclav versus the placebo group. The response to endobronchial infection, why we need such a long time, is probably related to mucociliary clearance and probably a viral initiator as well. But the key thing I always tell doctors is please remember that not all cough is PBB, okay? In Australia, because we don't use antibiotics a lot for acute cough, it's actually quite common. It's going to be very different in different countries. And some people tell me it doesn't even exist in where they practice, and it's probably because the GPs throw a lot of antibiotics around. Okay. So if the cough doesn't settle or if the cough is recurrent, they certainly need further investigations to actually elucidate the reason for their cough. So what about follow-up studies? This is again Danelle's work. We took the children referred to us for chronic cough. They underwent bronchoscopy. A subgroup had PBB, and we followed them up. And you can see that not everybody was followed up, but we assumed that those who were not followed up were actually well, because otherwise the parents would come back. So this is the baseline characteristics. So you can see there they see doctors a lot. And on her follow-up, she actually found that about 8% had bronchiectasis the 2-year mark. And when you look at the factors that are associated with bronchiectasis, there was really only 2 factors that was significant on the multivariate regression analysis. That's presence of Haemophilus as well as recurrent PBB. And that's why we define recurrent PBB as more than 3 episodes per year. Okay, and this is Tom Ruffles' work. He's a fellow that was with us for 2 years in Brisbane. He's gone back to England, and this is 5-year outcomes. So instead of 2 years, we have 5-year outcomes. And this is what he found. Some children were well at 5 years, so 32%, about 60% still had symptoms, and some of them had bronchiectasis, as you can see there in the kids who had symptoms. Some had no PBB, some had non-recurrent PBB, and some had recurrent PBB, as you can see the figures there. But what was interesting is some of these kids also had concurrent asthma. So in terms of inhaled corticosteroid use, you can see that it varies between the group, but they are real inhaled corticosteroid use when we don't have data on all their lung function, but the group that we had data on, they all had airway hyperresponsiveness as well. And so I think most of you would know this paradigm. You got PBB, chronic suppurative lung disease, untreated, leading to radiological bronchiectasis, and I've mentioned about PBB micro, PBB clinical, following on to PBB extended, and then recurrent PBB. So with Tom's work now, we've actually kind of put this here. We can't call it asthma because we didn't have a very solid definition. We have to call it an asthma-like phenotype because they responded to asthma-like treatment in terms of inhaled corticosteroids. So I think we're going around a circle where the old days of wheezy bronchitis is probably PBB plus asthma, and we need more data. We need data from other countries to see whether our data is actually can be solid enough to be replicated in other countries. So I'm not making it up. So PBB is now recognized in America as well. I mentioned the CHEST guidelines, but this is the ATS, patient education guideline, where they talked about PBB, and they also talk about the consequence of bronchiectasis. So should we be using longer antibiotics? This is a study done by the UK group, published 2 years ago now. I don't know whether you know, but Mark Everett's group, they actually say that after the cough finishes, you should continue antibiotics for another 4 to 6 weeks. So you could go up to 3 months of antibiotics. Now we think that that's a little bit too long. Parents wouldn't want it if the cough disappears. But anyway, this is a retrospective study where they looked at children treated for 6 weeks versus children treated for 2 weeks. And what they actually found on regression, that those who received 6 weeks of antibiotics were less likely to have recurrent PBB. So it's a study that is yet to be done, but I don't think it's going to be that easy to do because parents won't want to use such long doses of antibiotics if their cough settles down. So in summary, I'll have to say that PB is common in some settings. I've shown you some in Turkey, but it's not as common as it is in Australia. I've talked about the clinical recognition of a child who otherwise generally looks well. You can't find anything else other than a chronic wet cough. I've shown you the follow-up studies, which is taking it seriously if they've got recurrent PBB, and some of them may develop asthma type phenotype. I've shown you the pathobiology in terms of the immunity, the microbiology, and the inflammation. And lastly, I'd like to say that PBB is important because we need to know that some of them actually do develop bronchiectasis if left untreated. So I've got plenty of my research and collaborators to thank for. And this is a picture of late, and this is COVID time, so that's then we've got. That's all.
Great. It was a great talk, Dr. Chang. Thank you very much. Very inspiring.
Dr. Chang'in konuşması bitti.
I do have two quick questions, actually. First one, we are reorganizing our bronchoscopy form, and we were just wondering, do you use BS score in your daily practice? Because it's a very detailed form and...
No, we don't, because we're very lucky in Australia. All our specimens get sent for cellularity count, and they all get sent for microbiology with quantitative microbiology. So we don't actually use that score on a clinical level, but we do use it on a research level.
How do you evaluate secretions in your daily practice? How do you write them in your bronchoscopy form?
Gut form. So we say that a lot or a little bit, and obviously it's not repeatable when it's done like that because I haven't.
Okay.
But the ones in my research group will do similar stuff, but we got a big department, so
okay.
Yeah.
Okay. And what do you think? What's the role of chest physiotherapy and bronchodilator in treatment, in PBB treatment?
Yeah, that's a very good question. I mean, we don't subject them all to physiotherapy only because the cough goes away after 2 weeks of therapy in most of them. So if you refer them to physio, then you got to get physios involved, and then the parents also have to do another burden of care. Until you find that physio is helpful by either reducing the duration of cough or reducing recurrent PBB, I don't think it's necessary at this point in time. In terms of other treatments, I think it's left to be done. I mean, maybe we shouldn't be using so much antibiotics. We need to elucidate, whether there are any other possible treatments. I don't know, but at this point, that's the only thing that we have.
Thank you very much. Really, it was a very nice overview from the first mouth. You are one of the founders of this protracted bacterial bronchitis. Now I'm passing to the questions. The first question is from Professor Elif Dagli. Did you see less attacks of PBB during the pandemic?
Yes, we definitely have less. I mean, we don't even have bronchiolitis at the moment. So so it's obviously I think what actually happens is children get a viral infection, and then they get a secondary bacterial infection. I think that's the most likely scenario. And when they get recurrent viral infections and the cilia doesn't, this is all guess, right? Um, I can't prove it. And then when they get recurrent viral infections, the cilia doesn't recover, and then they're more likely to get another bacterial infection. That's what I think.
Yeah.
But obviously, you
And
obviously measure it. So
another question from the username Vivek. The question is, any role of doing induced sputum to achieve microbiological proof?
I think if you can do it, you'll be very good. So it's not that easy. People say it's easy. So if you talk to Heather Zah, she says it's really easy. But I can tell you it's not that easy. I mean, you guys do CF as well, so you would know that it's not that easy, especially in the young kids.
And another question from Professor Dagley. Did any of the PBB patients develop COVID? If so, what was the clinical course like, thinking the interleukin-1 aberrations?
You know, I have not seen a single child with COVID. So my hospital, which is the only tertiary hospital, we only had 8 children, and all of them came in and went out. So I can't talk about COVID. I'm sorry. So,
It's a good thing.
Yeah. Another question is coming from the other side of the world, from Chile, from Susana Soto. Have you seen difference during last year with children at home because of pandemic measures?
yeah, we've got less respiratory infections, that's for sure. So we're doing bronchiectasis studies, and the rate of exacerbations have gone down as well. So I think all respiratory infections have gone down.
Another question from Peter Povnek, and he asks, and did anyone look at the possible role of secondary ciliary dysfunction and structural cilia damage due to bacterial inflammation? Could it play a role in difficult prolonged recovery?
Absolutely, I mean. That's a great question, Peter. I think that's a real major thing, but as you know, it's not that easy to do. And as I mentioned, I think epithelial component is important, but we actually haven't done that work whatsoever because I've got no expertise in cilia stuff.
Another question is coming from BE. What percentage of PBB do relapse in your cohort, and what percentage progress to develop bronchiectasis?
So it's around 8% that then have bronchiectasis down the track, and recurrent PB, depending on whether you exclude the ones that doesn't get follow up. If you exclude the ones that don't get follow up, then obviously it's higher. But I think we should assume that they're all well, the ones that don't get followed up. So it's probably about 20% get recurrent PBB. But again, it's age dependent, so the older ones are less likely to get it.
Another question is coming from one of the authors of the publications that you have shown, Demet Can from Turkey. She asks, have opinions changed about the Association of Ebv with Bronco Malaysia?
I don't know whether there's any standard opinion per se. I mean, the thing about Malaysia is that when you got chronic inflammation, the airway also becomes a little bit Malaysian. Well, at least that's what we've been taught. But proving it's a different question altogether. But we know that at least kids with significant tracheal Malaysia, who actually come without a lot of problems in terms of infection to start off with, but come with wheeze, for example, and you follow them up, they are more likely to get respiratory infections. So I think there's no doubt that Malaysia probably plays a role. As to how big that role is and how common it is, I can't answer that question.
Another question from Ali from Turkey. Since we may not perform bronchoscopy to all children, could deep throat culture be useful?
Deep throat culture is probably not useful. I haven't shown you the data, so one of my postdocs have looked at nose versus throat versus BAL and nose plus throat with BAL, and followed up with a microbiome study, and you miss a lot of stuff. So not good enough.
Thank you very much. These are all questions from the chat box. I think it's now nearly midnight in Brisbane. We had more than 100 participants from 5 continents except Antarctica. I don't know any scientists working on PB in Antarctica now. So this lecture was listened from all over the world. I'm thankful to all participants and more than 12 countries, as I just at the first look, I'm aware. And I'm happy to have many participants from Indonesia. There are so many attendees from Indonesia. So thank you very much. If there is no question. So I'm just, I would like to say good night to you. Good morning to some people in America. And good afternoon to the Europe and Asia. Thank you very much, really. It was a pleasure, and we are so thankful for your really great support.
Pleasure. Bye-bye, everyone.
Thank you. Bye-bye.
Good night.
Bye. Bye. Bye.
Bye-bye. Thank you.